Black lights and booze burn when I record for Watts. And every black like Troy Davis who never had a fair shot. All black everything, everything black. Culture over everything, y'all. We taking it back.
Welcome. My name is Mark Anthony Neal. I am the James B. Duke Distinguished Professor of African and African American Studies at Duke University and the host of the podcast Left to Black, now in its 12th season. Today's episode, which we are taping live on Left to Black, is a collaboration with the National Clinician Scholars Program, and we are honored to welcome Dr. Oni Blackstock for conversation this morning. Dr. Blackstock is a primary care and HIV physician, is founder of and executive director of Health Justice, a consultancy that supports health-related organizations to center anti-racism and equity in the workplace and to reduce health inequities in the communities they serve. Dr. Blackstock previously served as an assistant commissioner for the New York City Department of Health and Mental Hygiene, where she led the city's response to ending the HIV epidemic. Dr. Blackstock holds degrees from Harvard College, Harvard Medical School, and Yale School of Medicine. How are you doing this morning?
I'm doing well. I'm really excited to be here in conversation with you, Professor Neal.
So I want to start, with the long game of your career, because you earned your reputation doing work around the HIV epidemic. And I know we typically don't think about the ways in which some of the knowledge that was generated in response to that really is a connective tissue to what we're experiencing now and dealing with COVID. But, as it's the 30th anniversary of Magic Johnson announcing his HIV, talk a little bit about your early research around HIV and particularly what that meant for you as a Black doctor trying to deal with this particular dynamic.
Sure. Wow. So I guess I have to go back to, I think when I was in medical school, I actually I went to Harvard Med School and ended up traveling to Ghana in West Africa and also to Durban, South Africa, where I was doing sort of HIV related work, really focusing on adherence in particular, whether patients are taking their medications as prescribed, because for HIV in particular, adherence to medication is really important in order to suppress the virus. So, I was there, it was like doing global health work. I was like, this is so exciting. And then I came back and did a community health HIV rotation here in New York City with a group of federally qualified health centers called Community Healthcare Network. So they were in the Bronx, in East New York and Brooklyn, in Harlem, Washington Heights, East Harlem. And I basically saw a lot of what I was seeing in West Africa and South Africa. I saw it here. And I think it can be very sexy and kind of romantic for some folks to go to do global health work. And I think it's important. Obviously, there's a tremendous need and probably even greater need in less resourced countries than here in the United States. But when I came back, I said, oh my goodness, I can do this work, right here. And I ended up doing an HIV fellowship after residency at Harlem Hospital, which is in central Harlem, which used to be the epicenter of the HIV epidemic, and still to some extent remains the epicenter for the New York City HIV epidemic. And so I took care of patients who had advanced, AIDS, had opportunistic infections, just things I think many people didn't realize, conditions that people would be surprised that people here in the United States had. And so just continued focusing on HIV clinically, but also ended up going to the clinical scholars program at Yale, getting research training, and then starting a career in academic research, where I really focused in earnest on HIV, particularly as it impacts cisgender, Black and Latina women, and then moving more towards both cisgender and transgender Black and Latina women. So that was kind of my path to HIV.
Yeah, and since you just mentioned it, talk a little bit about how important the National Clinician Scholars Program was, both for you coming in, but also in this role now where you serve as a mentor as opposed to a mentee.
Right. Yeah. So actually, it was actually when I was at Harlem Hospital doing my HIV clinical fellowship that I started doing like some research projects. I was actually interested in this question of how does trust in one's primary care doctor, HIV doctor impact adherence. And I was also interested in this question around sort of hope and optimism and how that impacted adherence as well. Anyway, so I ended up doing a study. I collected all the data, but I realized I didn't know how to do the analysis. And I just ended up sort of having all of these questions that were coming up, and I just didn't know the methods that were needed to sort of answer them in a rigorous way. And so decided obviously to apply to the Clinical Scholars Program, and sort of like, got really intensive training in both qualitative and quantitative methods there, and ended up having really great mentors, did primary data analysis, did secondary data analysis, did a lot of different types of studies that convinced me that I did want to spend at least the next step of my career in academic research. And I was very fortunate. You mentioned that this idea of mentors. I have a really wonderful mentor, Dr. Chinazo Cunningham, who folks in the audience may know, who is a substance use expert and who was my mentor from residency. And I honestly probably would not have gone into academic research if I didn't have her as a mentor. She really pushed me to go into research. She said I could do this. And I knew she would be someone who would read every line of my grant proposal. You need someone who is going to be committed to you, who's going to meet with you every week. And so after I left the Clinical Scholars Program, I went to Montefiore Medical Center, which is where I did my residency in the Bronx.
Up in the Bronx.
In the Bronx. And I went back there, I returned there because I was like, this is home to me. And so started my academic research career there.
Okay, so are you born and raised in the Bronx?
No, so I'm actually from Brooklyn, New York.
Okay,
grew up on the border.
I'll let you pass with that. I went to high school in Brooklyn.
My second home. I always say, was it the Bronx? Okay, the Brooklyn made me, the Bronx raised me. So I just feel like so much of my clinical perspective, all of that training happened in the Bronx.
As someone who did research or does research on viral infections, at what point, late 2019, early 2020, did you know, or you were convinced that something was going to happen that wasn't going to be good, and it also was going to have a disproportionate impact on the communities that you serve?
Yeah, no, so this is interesting because I ended up just transitioning from academic research to public health to government. I went to the New York City Health Department, where, as you mentioned, I was an assistant commissioner, and where I oversaw our city's response to the HIV epidemic. And it was in that capacity that I actually, at the end of February in 2020, I was the senior doctor on call for the health department. So that means we get calls coming in from emergency departments, clinics from all over the city. And we were getting slammed with calls with healthcare providers who were concerned that patients who were coming in with flu-like illness had COVID-19. But I don't know if you may remember that the criteria for testing was very narrow, right? Like if someone had to have been in Wuhan, that was one of the criteria. I remember getting a call about a case of a patient who had a flu-like illness, who I think had gone through Wuhan airport. And because they had not physically been in the city, they didn't qualify for testing. So the criteria for testing were so incredibly narrow. And I just had this horrible feeling that we were missing cases. I was like, this is not good. And I know it was very challenging at the health department. Internally, many of the folks who work with the Bureau of Communicable Diseases, who had a history with dealing with these types of pandemic threats, they were very concerned. And this was in contrast to what we were hearing from Mayor de Blasio, who was telling everyone to calm down, there's no need to shut down, anything like that. So it was a very, very scary time. And many of us at the health department knew that something horrible was about to begin. But because of politics and I guess other interests, we really weren't able to really communicate that to the public. And I think honestly, I was so in it that I couldn't even think about I mean, of course it made sense that Black and Brown communities would be disproportionately impacted, but I think I was just I was sort of incredibly fearful just that this people aren't getting the information that they need. And then we ended up seeing, as this pandemic progressed, more and more actually worsening inequities as the pandemic progressed.
How did the crisis really change your mission around public health. I mean, and you could talk a little bit about transitioning from the city of New York, to health justice, and how important that transition has been in this moment.
Yeah, so for me, like I came to HIV because for me, HIV is like the lens through which I you can see the ways in which racism, sexism, homophobia, transphobia all intersect with one another. I don't think there's any condition that has such stark inequities. So when we look at new HIV diagnoses in New York City, about 80%, 90% of the women who are transgender or cisgender are Black or Latina. And then among men, about 80% are Black or Latino. These issues, these systems of oppression have always been a priority for me to dismantle. And when this pandemic happened and we started seeing what was happening, when we started seeing the social uprisings happening in response to George Floyd's murder by police, it just brought a lot of these issues to the fore. And I had actually the year prior created the first racial equity and social justice initiatives program at the health department within the Bureau of HIV. And so I was like, this is work I want to do and really want to focus on in earnest. And so last year left the health department to focus on health justice, my consultancy.
One of the things that's interesting about this moment, in your work in particular, right? We have historically, when we talked about Black doctors in Black communities, right? Black doctors were some of the most trustworthy figures, not only to provide medical expertise, but also thought of providing certain kinds of leadership within Black communities.
Yeah.
We're in this unique moment where so many Black doctors like yourself, like your sister, so many others on the front lines, trying to convince Black folks who have vaccine hesitancy, those folks who are COVID deniers. I mean, all those kinds of dynamics. What has the challenge been for you as a Black doctor? Because in my mind, as all this stuff is going on and I'm looking for trust figures, right? If a Black doctor says it, right? I've been raised to trust Black doctors, right? But it's a different kind of moment now. How have you dealt with some of those challenges?
Yes, yeah, that's been, I think that has definitely been a challenge. So I think for my sister and I, the work that we do is very like mission and purpose driven. And I used to just say, our parents were, part of the Pan-African movement. Like we went to anti-apartheid rallies, anti-police brutality. Like this is just the space that we've always been in. And so really doing what we can to lift our community is a priority for us. And it's always been. And I think, we come with that background, I think we come to this, but we're also, we've been, this in some ways indoctrinated, into, the healthcare system, the medical system, which is steeped in white supremacy culture. And so, I think we kind of have these different vantage points. And so I think for some people within the Black community that we are seen as trusted messengers in terms of this information, particularly around COVID-19. Yeah. But the reality is that many Black people have had very negative experiences with the healthcare system, including with Black doctors. So I think for us, I've had people ask me if I'm being paid by pharma talk about the COVID-19 vaccine. I don't say wish, I don't mind being paid, but no, I'm not being paid. I gotcha. But so it's sort of like, there are some folks for whom the fact that we're Black doctors appeals to them and resonates with them and makes them more open to hearing what we have to share. But it's not like the case for everyone. And so it's been really interesting to, hear, there's so much mistrust. I think Black people and other communities of color have been so marginalized and so oppressed and, and have this justified mistrust so that even when they see someone who looks like them, but is representing the healthcare system or the medical system or research, that is often not enough. to counter, all of the experiences that people have had throughout their lives in this country.
Does it trouble you as a researcher, as a medical profession, that we're in this weird moment where expertise is under siege?
Yeah, it's well, it's interesting. It feels like, when you talk about this expertise thing, I was actually thinking recently how there are just so many like armchair experts around in like healthcare now, right, and in public health and epidemiology. And that sometimes I even have to check myself too, to be like, wait, is this something that I feel like I can speak on? Because yes, I'm a public health practitioner. I've done research, but I'm not an epidemiologist. And so at least for myself, I feel like I've tried to speak to the issues that I feel more knowledgeable about, such as like racial inequities in terms of the impact of the COVID-19 pandemic. But no, there's definitely like an anti-science, anti-intellectualism, flavor to all of this. And I think really what it comes from is, the dominant culture, and that's just the way that people are treated, has different effects on different people. And so I think for people of color, it can often result in a certain type of mistrust. And I think the same thing we see sort of like the kind of like on the spectrum, some of the other side, a similar sort of mistrust of science, but among sort of anti-vaxxers, maybe more rural white people, more lower income white folks. But it's the same thing. I mean, everyone's being, sort of oppressed and marginalized in different ways. Obviously, people of color more so, but we know that racial differentiation has been used as like a wedge to keep, poor white folks separated from poor people of color, so that we don't join forces, to change the status quo. So yeah, this is a time where I think all of these different factors, it's sort of the confluence of many of these different forces, and we're sort of seeing the pandemic sort of shine a light on them.
There's a great question that came into the chat. Dr. B, it often seems like a natural progression for physicians to move into spaces where they start research on social justice systems. This is often not the case for nurses. Nurses are still viewed as physicians' handmaidens or competition. Do you have any advice for nurses who would like to do social justice and health equity work outside of the academy or healthcare centers, as a lead administrator of a center, et cetera?
Oh, that's a really important question. And I think actually over the last few years, I didn't even know this was a term, physician supremacy, but we have a culture within medicine, within healthcare, I should say, of physician supremacy, where, and I think a lot of it has to do with sort of the history of medicine, but also because, so much of the money and the profit that is made within healthcare is from, reimbursable procedures or whatever it is that's, physicians provide versus valuing the care that nurses provide. And I know that nurses can have many different roles within healthcare. I would say like there are people like Monica McElmore, like at UCSF, who are nurses and who have really just been really incredibly dynamic and forceful in terms of shining a light on social justice issues. And so I would say, find those folks who, are doing what you admire and, are sort of like out there and, speaking up and, ask them, talk to them about like, how did they get to where they are, just really understanding what their path is and just recognizing that everyone's path is going to be different. But I have found it helpful to like, when I see someone who's doing something that I admire, to reach out to them. And because people love to talk about themselves and to be like, how did you get to this point? What are you doing? But the reality is that, unfortunately, MDs, if you have an MD, people just assume that you can speak to anything. We see this in public health as well. Like MDs lead the public health department, same thing at New York City Health Department. And based on there are people who are knowledgeable who have other backgrounds, other educational backgrounds. So I think it's such an excellent question. I have to think about this more, but again, I think as a first step, identifying those folks that you look up to who are doing the work and reaching out to them to understand what their path has been like.
In that same sense, you've made this, shift into the research world. What do you say to folks, to continue to encourage folks who still want to stay on the clinical side, and to value that experience, as the way that it's also important to value the research side of it?
Yeah. So for me, I actually still see patients at Harlem Hospital. So when I left research at Montefiore and went to the health department, I actually started seeing patients one afternoon a week at Harlem Hospital at the HIV clinic there, which is where I worked about 10 years ago when I was a clinical fellow there. And because for me, clinical care is like, it's like my core identity as a healthcare provider. It's where a lot of the questions that I have come from. It's like the conversations with my patients. I remember, talking to a patient a few months ago who had a young Black man had 3 family members die from COVID-19 and still didn't want to get the vaccine. And we had a really great conversation. By the end of it, he was willing to get it. But like, if I had not had those type of interactions or encounters, I wouldn't be able to speak on any of these issues. So I feel like clinical care keeps me very grounded. And it's like the bread and butter of medicine. That said, I know that it's very challenging to only provide clinical care because the way the system is set up, you're seeing tons of patients. There's very little time to take care of yourself. And so many people, will balance clinical care with administration or clinical care with teaching or clinical care with research. And I think that's really important because the way the system is set up, it's, a recipe for burnout for many people.
Absolutely. You co-authored a piece last month with Alexandra Skinner and Julia Raifman in the Washington Post about breakthrough infections and how the same level of racial disparities that we saw in vaccination rates, in infections very early on in COVID and going through, we're now seeing the same thing in terms of breakthrough infections. Talk a little bit about that dynamic and what do you think is at play in this?
Right. Yeah. So, I was really interested in this question because there's actually still very little data out there in terms of breakthrough infections by race, ethnicity. Different jurisdictions some will provide detailed data, some don't, some will provide it by age, by gender, but very few are providing this data by race, ethnicity. And we know that if there's no data, it's no problem, right? Like if there are inequities, we won't know about it. So this happened on Twitter, the collaboration for that op-ed piece. I actually said, does anyone know anything about like breakthrough infection data, stratified or separated out by race, ethnicity? And then Dr. Julia Raifman, she was like, oh, you should, Seattle, King County out in Washington is doing this. And what we saw was that Black, Latino, Native American, and Pacific Islander Washingtonians were actually more likely to have breakthrough infections as well as hospitalizations and deaths. So, and I think people, think like, oh, it's a vaccine. It should have the same level of efficacy, for everyone. But the reality is if we haven't addressed the underlying factors that cause inequities, a vaccine isn't going to completely correct that, right? So we haven't addressed the issues around higher risk of exposure that Black, Latino, Native American, Pacific Islander communities experience. We haven't provided, paid sick leave. We haven't, made, situations safer for, workers who are on the front line. And then on the other side, we're dealing with, higher levels of comorbid conditions among, people of color as well. And this is because of issues such as access to care, lack of insurance, the weathering effect. We know that just dealing with the everyday impact of racism has a physiologic toll, and that then ends up manifesting itself in the body and places people at increased risk for high blood pressure and diabetes, which we know leads to worse outcomes for COVID-19. So none of these factors have changed, like none of the underlying structural drivers have changed. So we ended up looking at a number of different jurisdictions and found a little bit more data, but we still need more data to really to see what is the extent of these inequities that we're seeing in breakthrough infections, because this is important in terms of booster recommendations. Right. At the beginning of beginning of this year, my sister and I wrote 2 op-eds for the Washington Post. And one of them really spoke to the need to consider race, ethnicity as a criteria for vaccines, right? Like because of this weathering effect, because we were seeing many of the younger folks who were dying of COVID-19 were Black and Latino people. Because of the factors that I had mentioned previously. And so we were seeing, age cutoffs, not as the criteria, not race, ethnicity as a criteria. So it just speaks to like some of these issues, and we really need more data, just in general by race, ethnicity, but including on breakthrough infections.
Yeah, I read a piece earlier this week as we're now, extending the vaccine to 5 to 12-year-olds. And how a lot of states are not really collecting good data around the racial dynamic of who in the 5 through 12 age is actually getting the vaccine. How much of an impact do you think that's going to have going forward?
Oh, yeah, I think it's going to be a huge issue. So I have an 8-year-old son, and I took him. This is kind of like a little bit of an odyssey. Maybe the day after it was approved, I took him to what I thought would be a walk-in site at the American Museum of Natural History, not too far from Harlem where we live. And there was a whole line of parents. They were like, we're not accepting any more walk-ins. But they sent us to East Harlem, actually to the East Harlem Action Center, which is actually one of the, which is a site for the New York City Health Department. Yeah. And I was online, and I was sort of looking at the demographics of the folks who are online with us. And I'll just say that. Would you say?
In East Harlem.
In East Harlem, yes. And I would say that the vast majority of people were not from East Harlem. The vast majority of folks were white appearing. East Harlem is primarily Latino, a sizable number of Black people as well. But just seeing that actually concerned me, because I said, it's like the same thing that we saw when adults were getting vaccinations. And we know that there's a lot of concern that all parents have around vaccinations for children, but probably a little bit more stark when it comes to, Black and Latino families are concerned as well. So I actually ended up posting a picture. I tell my son was like freaking out and crying. And he finally got it together. I was like, let me take a picture of you with your thumb up after your vaccination, because I wanted to just post it just so that people on social media, so people could see a little Black child getting a vaccination, that it was safe, that he was okay. I think I'm concerned actually that we're going to continue to see some of these same issues impacting children as well.
Yeah, there's a question coming from the chat from the audience who asked, I was wondering if you could expand on a prior thought of yours on the role of physicians in health equity work, knowing that a majority of individuals' health is determined outside of healthcare. Do you think there's a line where physicians should leverage their own social capital to highlight expertise from individuals like urban planning, housing policy, or educators?
Yes, yeah, no, I think that's such an excellent question. The reality is that whether it's deserved or not, if you do have a medical degree, people, like as I said before, people look to you for expertise. And there are so many, I think, opportunities that we, as healthcare providers in general, and in particular in physicians, I can speak from the physician perspective, can help to elevate our voices and the stature that we have. And again, it's not deserved. It's not earned necessarily, that we have to speak on issues. So for instance, this is obviously healthcare related, but I speak often around global vaccine equity. So like next week, I'll be speaking in Times Square at a vigil on global vaccine equity. But and often when there are speaking opportunities, are like, can you as a physician come talk, because people will listen to you. But again, like the question, person who asked the question was asking about urban planning. I mean, their agriculture, it could be like anything. I think that because our voices are valued for whatever reason, that can be leveraged to attention to many issues. And so, I did my residency at Montefiore in the primary care social medicine program. And so much a part of that training is really about understanding sort of the broader context for health, that so much of health is informed by people's experiences outside of the healthcare setting by these various social and structural factors. So yes, I think we actually have, it is a responsibility to speak out on all these issues, because they all ultimately impact health. And we often see the manifestations of that when our patients come to see us in clinic or at the hospital.
Absolutely. You mentioned the question asked about, leveraging social capital. Social media has been a gift and a curse. But there's no question that so many more people in the world know about the Blackstock sisters because of social media. How important has social media been for you to do the kind of advocacy work that needs to be done in this moment?
Yeah, and I really appreciate that question because I would have to say, I don't know if there are folks in the audience who've worked in government, but I was working as I said, at the New York City Health Department up until the middle of last year, and I did not have sort of the freedom or the latitude to be able to tweet about certain things. And that was very frustrating to me. Working at a city agency, I couldn't tweet about the NYPD, for instance. If there are things that were going on that were unjust or concerning, or just the institution of policing is concerning. But that's like another issue. And so having left, the health department and left, I was in many ways muzzled when I was there. Leaving and having my own business, I now am able to use social media as a platform for advocacy, really to bring attention to many issues. So for instance, the op-eds that I wrote with my sister around, prioritizing Black people, other people of color for vaccines, that just started as a post, a Washington Post, I think editor was like, this looks great. Do you all want to write an op-ed about it? And so we were able, it really just helps to amplify whatever, the message is. And so I am incredibly grateful to social media for that. I have to say the flip side of it is that it does put you sort of in a place where, there are many people who, because I often will tweet about, racism and white supremacy as well. And so then you get inundated with hate mail and threats and things of that nature too. So it has the flip side of that, which can be quite negative and somewhat traumatizing. But it's also has the positive of being able to amplify and highlight issues that are of importance to us.
I want to shift a little bit to talk about self-care.
Yes.
And this has been a big issue for many folks in the healthcare profession over the last 18 months. How have you figured out a model to be able to do the kind of important self-care that keeps you on the front lines, right? Because the bottom line is, we need folks like you out there, but folks need to be able to take care of themselves at the same time. So what have been some of your self-care strategies?
Right. Yeah. And just to say, we need the system needs to change, right? We can't self-care our way out of all of this. So just to say that, but in terms of self-care, I think, obviously that's a priority. I think we've heard more and more about it during the pandemic. For me, that involves, I meditate often. I actually started a few months before the pandemic started, because my job at the health department was incredibly stressful for many different reasons. I started a meditation practice. I started also a daily, well, now no longer daily, but a daily yoga practice, but I do work out or do some sort of activity every day, because actually also take voice lessons. My voice teacher is also kind of like a wisdom teacher for me. And when I was working at the health department, it was very stressful. I was actually experiencing depressive symptoms, a lot of symptoms of anxiety. And my voice teacher said, just doing 15, 20 minutes of exercise every day, can help just in terms of lifting your mood, things like that. So I said, okay, that's great. So I just started doing yoga every day. I do Peloton. So I do a lot of physical sort of movement work, exercise. I have a wonderful support network. I have a wonderful partner. I'm very close to my sister. So all of that is incredibly important. But just to say, we need to have a culture of community care, of collective care. This pandemic, I think, has shown us, all of the gaps that exist in terms of the support that is out there for everyone, including obviously healthcare professionals. So we need to think about, how, at least within the healthcare system, how things can be changed. I don't know if they can, because it's a for-profit system and it's really, driven by capitalism. And I think which is inherently extractive. And that's why one of the reasons so many people are leaving the healthcare. That Ed Young had that article yesterday, I believe, in The Atlantic, about droves of healthcare providers are leaving the healthcare system.
Another question from the audience references a comment from Dr. Monica McLemore, who suggested that clinician scientists should think about new ways to do the work that they do. What kind of innovations do you think might be important in this particular moment to sustain the kind of impactful work that needs to be done?
Yeah, this is totally not necessarily innovative, but it's something that like there's just been a lot of resistance to doing. And I think there are probably people in the audience, colleagues in the audience who do this, but I think all the work that we need to do must center those who are the most burdened. Like you cannot go wrong by listening to the voices and being led by the folks who are the most impacted. And currently the way that research is set up and funding is set up by, NIH, for instance, like it does not allow for that to happen and for the relationship building that needs to happen. So there just needs to be really a change in terms of, timelines, timelines for submitting grants, what is the expectation, what type of work is valued, all of that. Yes. And that's probably actually one of the reasons why I ended up considering other pathways besides research, because I felt very frustrated. My focus was on HIV and, women of color. And I ended up getting so many comments from reviewers about, is this really an issue? Is this really a problem? And then when there would be like a more senior person, often white, who was who sort of jumped into the area, they would get funded versus me as a sort of a early investigator. So I think the priorities, NIH, I think is really trying to work on addressing structural racism, but I think there's substantial work that needs to be done.
Yeah, another question that's come from the audience is really this question about whether or not med schools and their curriculum should be more open to some humanities curriculum, right? To generate, more deepening empathy, amongst medical students.
Oh, definitely. And I think there are schools that are already doing this. Like I think Mount Sinai Medical School has a track that is focused more in humanities, but I think it just speaks to the fact that we need people who are, who are coming from, not just coming from science backgrounds, people who have, varied interests, and then and the training that's needed to be a healthcare professional, a physician, nurse. It shouldn't just be obviously focused on science. And I know med school curriculums are evolving, but they really do need to catch up with the times, sort of in terms of like anthropology, sociology, the things. I mean, that's a lot of those areas are much more important than biochemistry. I'm sorry, I don't use my biochemistry, when I'm like prescribing or treating patients.
This has been a special edition of Left to Black in collaboration with the National Clinician Scholars Program. We've been joined today by Dr. Oni Blackstock, a primary care and HIV physician, who is founder and executive director of Health Justice and consultancy that supports health-related organizations to center anti-racism and equity in the workplace and to reduce health inequalities in communities that they serve. She's previously served as Assistant Commissioner for the New York City Department of Health and Mental Hygiene, where she led the city's response to ending the HIV epidemic. It has been wonderful to talk to you today, Dr. Blackstock.
Thank you, Professor Neal.
Thank you for joining us. Thank you.
Thank you.
Black lights and booze